Welcome to the Student Safety Wellbeing Advisory Committee, meeting number 7 on this beautiful day. I'd like to call the meeting to order and determine a quorum. And I believe we do have a quorum. Can I get a motion to approve the agenda for today's meeting?
So moved.
That's second.
Motion approved. All in favor say aye.
Aye.
The ayes have it. Motion carries. Let's take a look at our new business for today. We are very excited. We've got a presentation by Dr. Teneza Mora, our health officer for Calvert County Calvert County Health Department. And I believe Denise Dickerson, the interim director of behavioral health, will also be here to speak about some wonderful things that we've been really interested in getting ready to hear and add to our data collection process. So, with that being said, I'd like to introduce Dr. Teneza Mora. And if you want to, you can come up right up there. Yep. You can have a seat, get nice and comfortable. We appreciate you being here today. How are you?
Hi, I'm doing well.
Very nice to meet you.
Very nice to meet you too. Yeah, thank you very much for this opportunity to present to you today. And I'd like to thank Denise for tag teaming this with me. And also acknowledge our health promotion staff who provided information, as well as our epidemiologist who assisted me with this one. Sorry about that. Can you hear me okay now?
There it goes.
Just do this kind of thing. So, great. Oh, sure. I guess the next one. Oh, there it is. So, you know, I mean, school health really, so before I came to public health, I came from the Navy and we did things just a bit differently, but I'm very excited to join the public health, our local health department, and be able to work with the schools. And, you know, as I've been here, 3 months, 6 months now, I'm understanding that our health department really collaborates with the school and a lot of other partners in the community. And I'm excited to know that we're doing that, because school health really is public health. And it's our opportunity to affect the young generation, you know, in the short term, help them prevent certain things, but in the long term, hopefully prevent a lot of those chronic illnesses that could afflict them in the future, including cancers, heart disease, and mental health issues. And so thank you very much for your time today. So at least, next slide. This is the agenda that we have today, and you're free to also ask us questions in the interim, you know, if there's any burning questions that you may have. But we'll start with the health trends for the Calvert County Public Schools, and then I'll just give a brief overview of the health department, which many of you may already know, and then those programs and services that we have there that really support the school system. And there's quite a few of them. Okay, so we will begin. Sorry. So we'll begin. I'll begin by describing the source of our data, and many of you are probably already aware of this, but it's the Youth Risk Behavior Survey and the Youth Tobacco Survey, which is an on-site survey conducted by the state and actually through the CDC every even years of the school years. And the data collected from here are goes through the CDC first, and then they are processed, analyzed, condensed, and then basically brought back down to the states. And we're unique in that in Maryland, 100% of our schools participate in that. That's not true for many of the other states. So, so the only limitation, or the limitations of this data set, is that it's delayed. You know, we're looking at 2022-23 data today in 2025. And so our experiences may have to supplement some of those. And then in some cases, there are questions that may not have been answered by too many students, so the data sets and N might be small, and so the you know, how to interpret it might be limited. But this is the best that we have, short of collecting the data at our health department as well, and so, but that's limited. So this is really probably the best data that we have for today. And everybody knows the reason for that. It's really to identify what those health needs are, and then to have our staff and the community members identify or devise interventions that can help, reduce certain trends that may be headed towards the wrong direction for our adolescents and for our youth.
Okay, so that I understand what you have shared with us, then this is fall of 2024 data.
This is actually 2022 to 23. So the fall of 24 is still being analyzed now.
Okay, okay.
And we probably won't even see a release of that until the latter part of 2025 into
Okay.
26. So there's like about a 2-year lag.
Okay.
And I apologize if this is data that you've already seen. I'm learning a great deal from it, actually, and it's giving me ideas on what and where our interventions, should really focus even more.
Great.
Any questions? Okay. So this survey actually helps assess 6 areas in adolescence, right? Physical activity, nutrition, alcohol and substance use, tobacco use, as well as those behaviors that put them at risk for encountering unintentional injuries or unintentional pregnancies and sexually transmitted infections. And so, the 1 hour or the 45 minutes is not going to be enough to cover all those 121 questions. But what we did was we selected the ones that we think may be most reflective of what, what we're trying to learn and what we're trying to achieve. Anyway, but this is a question, so this is a question that helps assess physical activity among our high school students and the middle school students. And this one shows the percentage of students who are physically active for at least 60 minutes per day for 5 days a week. Sort of like in the last, I believe this is like in the last 30 days before they took the survey. And this one says that we're doing well, but I think that we can, our students can improve. So this one says that 48% of high school students report that they're physically active for an hour a day, at least 5 days a week. And our middle school students are 56%. 56% of them are reporting the same. And this is higher than what the national average is and what the average numbers for the state of Maryland are. And so, as a health department and as a community, our goal would be to continue to encourage them to get physically active. So we could work a little bit more on that. Okay, any questions about that? Okay, let's see. Yeah, so this next set of slides actually are questions about tobacco use among our youth. So this one says it's the percentage of students who currently use electronic vapor products for at least 1 day in the last 30 days before they took the survey. And the electronic smoking products include things like the e-cigarettes, vapes, vape pens, hookah pens, and mods. And the overall numbers here says in 2023, 18.2% of high school students report using vapor products, and 6.8% of middle school students are reporting the same thing. And you're seeing a lot of movement of the bars there, but because some of those numbers are quite small, it's probably more consistent that it's, if we're looking at the trends from 2018 to 2023, those are probably fairly flat or unchanged. However, I don't have the data in here, but if you look at the data, or if the data from 2013 through 2023 is analyzed, there's a general decrease in the trends. The highest ones were in 2019, and they've been decreasing since then. But the numbers are still concerning, 18.2% for high school students. So compare that to cigarette use rate. So the same survey stated that about 3% of our high school students smoke cigarettes, so a lot less of them. So I think we can our goal is to drive those rates down, or those percentages down. I didn't show this here, but so among those who vape, 20.6% of those high school students who vape are smoking marijuana with their vape or THC. And those numbers are actually, or those percentages are actually increasing. And that particular act is actually the one that puts our students at risk for some of the adverse events of vaping, including the ones that lead to, you know, ER visits and potential hospitalizations. Okay. This is just a summary. So for Calvert County, 19.2% of our high school students report that they vape currently, and 6.8% of middle school students admit to doing so. And that those rates hopefully are decreasing, but we can do a little bit better. Next slide. So the next few slides, we'll go over the substance use, alcohol use among our high school students. And the question that they answered with this particular one was, you know, the percentage of students who currently drank alcohol, at least one drink of alcohol one day during the last 30 days before they took the survey. And the numbers here state that 26% of high school students admitted to drinking alcohol, and middle school students up to 7.6%. And these figures have really been consistent or no change from 2018 to 2023, although overall, if we were to look at the data starting in 2013, they're decreasing over time. But they still are using alcohol. So the numbers on the left regarding pertaining to the middle school students, those numbers are actually quite small, so it's hard to interpret the fluctuations that you see there. For interpretation purposes, those rates are probably fairly constant or unchanged from 2018 to 2023. Any questions about that? Okay, on this particular slide shows the response to marijuana use. So the question asks whether they currently use marijuana at least one or more times in the last 30 days before the survey. They took the survey, and this one shows that 15.6% of high school students reported use of marijuana, and then compared to the middle school students, 3.1% for the middle school students. And those rates really show no change. I'm sorry, actually, sir, so there's a decrease in the percentage of high school students who use marijuana from 2013 to 2023, but like in those last 3 years, it's been kind of constant and no real change. Any questions about that? Okay. On the next one, this one is a question that asks about student use of prescription pain medications without a doctor's prescription or without the direction of a physician. And this actually surprised me because I expected the rates to be lower, but they weren't. So high school students, up to 11.2% of them reported this behavior in 2023. And that's higher than the numbers or the rates that are obtained from the US in general. I didn't show them there, but the percentage of students, high school students in the US that use this medication is 4.4%, and yet our data shows 11.2. And it may be limited again by the number, the N, or the number of students, but you know, we kind of have to keep that in mind. And among the middle school students, 9% reported use in 2023. So although those look like, the rates there look like they're increasing, I think they're probably limited by the small numbers, and the actual trend is probably more flat. But it's 9%, so that's still higher than the 4% nationally. that's for high school students, so there's some use. And so I have to look for questions that help identify where they're getting this. So we have to kind of, that's our next to-do would be to look through, you know, how are they obtaining these? Okay, and then, so this is a good summary slide. It just says the percentage of students that take alcohol, use cannabis. And as you can see there, up to a quarter of high school students take alcohol. 7.6% of middle school students admit to using alcohol. And for analysis purposes, those rates are unchanged. And then same for cannabis use. So in the last 30 days, 15.6% of high school students admitted to using them. No change since 2021, although overall scheme of things, those rates have been coming down since 2013 when they started taking this data down. And then 3.1% of middle school students admit to using cannabis. Questions? Okay, now the next set of slides will show questions related to mental health. So these were included to help assess depression in students, other things that may be contributing factors to their mental health state. So this one, I'm sorry, I think I went one. Okay. This question asks the following. So has the student ever felt sad or hopeless almost every day for 2 weeks or more in a row for the last 12 months, and that they were experiencing these emotions intensely, that they aren't able to do anything? So that's actually the clinical definition of depression. So that is the clinical definition of a person who is depressed. And the rates are not insignificant. So in 2023, 33.3% of high school students reported experiencing this. And among middle school students, those rates are also not insignificant. They're in the 20s. Sort of didn't list my number down in here, but they're actually 34%. And that those had been consistent over the last 3 years that are shown here. And if we were to kind of pull back and look at what the rates were from 2013 and on, those rates have actually been increasing over time, gradually, but increasing. And I'd like to point out a few things here. It's notable to see that the percentages for female high school students and female middle school students,
Significantly.
you know, yeah, are a bit higher compared to the other groups that we've studied here. And so, questions about that?
Could you go back, please?
Yes.
The only question that I have is that it appears as if the jump in these numbers are pre-COVID and 19 and post-COVID, right? And COVID times, right?
They're pre-COVID, during, and then slightly, I guess, post-COVID or shortly after the
Okay,
peak.
and so we don't see a significant spike between the two?
Oh, between COVID and post-COVID? There, I would say, because I actually looked at these numbers, they are kind of within the confidence interval, and so although it looks like it peaks over there, where the orange bars are, in reality, those probably aren't peaks, that it's probably quite flat. And so this kind of it's an indicator that what they've experienced is still affecting them to date, possibly, and then there are probably new challenges that they're facing today.
There are probably newer challenges, but also one of the realities is that in the state of Maryland, for a number of years, this has been one of the state budget areas that's been overspent repeatedly, year after year. Mental health services for juveniles. And I say that having served on the Board for Legislative Oversight for the budget process. We've had a trend for the last 20 years of increase in need of support for juveniles for mental health. And a lot of folks would tell us that COVID changed the world for everyone in this area, but these numbers don't say that.
It actually may be early. It would be helpful to see what this looks like many more years down the road, but
Okay.
I think it's multifactorial. But COVID is a factor, but there are other factors,
There are other factors as well.
that are contributing to it.
Thank you.
Sure. I will just add that this is just a snapshot of symptoms of depression. There's other symptoms that we see post-COVID, most notably anxiety, adjustment disorders, things of that nature that may pose a more well-rounded picture of the other aspects of COVID. It's hard to look at simple symptoms of just one disorder, whereas we're looking at probably a larger, and we'll talk a little bit more about the other disorders and things that we see more commonly in our youth.
I'll move on to the next slide. This one asks about, asks the question if they ever seriously considered attempting suicide in the past 12 months before taking the survey. And in 2023, nearly 17% of the high school students reported this experience. And I don't have the information for the middle school, but I think it might be in a subsequent slide. It shows that peak also, but those are within the confidence intervals, and so it's probably fairly flat, actually. And then another question in here asks the question, like, in the past 12 months, have they ever been electronically bullied? And I picked this out because, you know, I said, oh, it could be interesting to know about this. And sure enough, there are a number of students that are experiencing this. So 14.4% of high school students reported having been electronically bullied ever. And among the middle school students, those percentages are slightly higher. So 34% of middle school students reported having been electronically bullied in the last 12 months before they took the survey. And if you look at the bars on the middle school section, under the female, you know, it's sort of rising. There's some increases in there. And those look like, at least from our analysis, that those were significant, that there's a rise in there. I couldn't say the same for, if you looked at the black versus white, that's not the same for the African American students. So I will have to look at that and to really see whether that's statistically significant. But at least, so there's bullying that's occurring, and it's occurring electronically as well. It could be influencing, you know, their mental health. Next slide. So we selected this question to see if, you know, they have what their thoughts are about speaking with and getting advice or getting help from adults. And so the question here, or this one asks for the percentage of students who most of the time or always feel like they're able to talk to an adult in their family or another caring adult about their feelings. And 49% of high school students responded yes to that, and 84% of middle school students did say that they had an adult or somebody that they can talk to. And so those, I think that for the high school students, those are probably going up in time, but for the middle school students, those numbers were dropping. And these were actually, there's some the difference is, I'm sorry, so the trend, there's a decrease, but there are some where they're not statistically significant. But if you look at the total number, so there are the percentage of students feel like they could talk to an adult is kind of going down over time. And so, like, we have to be there for them. And we may be able to, you may be, parenting, you might be, parenting education. But that's, we have to look at that a little bit more as to how to find a way to, or what messaging and what information, health information could be distributed to the community to help them with that. Okay, and this is just a good summary slide with the numbers in there. And so up to 33% of high school students have depressive symptoms, and then equivalent number of middle school students experiencing that too. And then it shows there the number of, or the percentage of students who attempted suicide or considered it and actually attempted it. Okay, we're gonna move on to sexual health. So the next ones, the next questions were selected to assess their risk for unintentional pregnancies and sexually transmitted infections. And this one asked the students whether they ever had sexual intercourse, and 27% of them reported this behavior. And that percentage doesn't change from 2018 to 2023. So there were no changes in that. Okay, and then the next question here, it was also asked of high school students only. So among those who had sexual intercourse, how many had 4 or more partners during their lifetime? And 5.5% of those students reported that behavior. Okay, and then this question asks about the percentage of students who used condom during their last sexual intercourse, and this is among the students who admitted being sexually active, and 53% of the high school students reported condom use. And not shown in here, we also looked into how many or what percentage of females who are sexually active used birth control pills to prevent pregnancy, and the data showed 28.5% of the females use birth control. Okay, any questions about those topics? Okay, I'm gonna move on to road safety. And so this question asks, in the past 30 days, how many times did a student drive a car or another vehicle when they were drinking alcohol? I would have wanted to see much lower numbers there. I mean, the percentages are low, but they're not 0, or they're not close to 0. 5.5% of high school students admitted engaging in that behavior. And then over time, it's unchanged, and it's occurring a little bit more frequently among the males than females. And this question asked students, whether they ever rode in a car with a driver who had been drinking alcohol. And this question was asked both of high school students and middle school students. And so the numbers are there. So 12.1% of high school students reported having this experience, and 20.9% of middle school students also reported engaging in this behavior. And so I think this kind of is an indicator, they will likely benefit from just reminders or education about drinking and driving, or talking to their friends or about drinking and driving. Okay, the next one here, nutrition. So I don't have too many questions in here, but this was pulled out of the Youth Risk Behavior Survey as well, and it shows that 26.3% of high school students reported being obese or overweight, and that 7.6% of high school students reported not eating vegetables in the past 7 days. And there's a small percentage, 7.5% of students had child food insecurity. So that figure is actually not from the Youth Risk Behavioral Survey, but from a survey or information from 2022 Feeding America. Okay, and then this is the final data piece that I have here, just on immunization rates. But this is the only one that I could really see from the Center of Immunization at MDH. And this one shows the immunization status of kindergarten students as they enter the school. So they're required to have immunizations before they enter kindergarten, and I've listed the 5 vaccines in there, and they have to be up to date for those vaccines, and they're up to date if they receive 4 of the tetanus, diphtheria, pertussis vaccine, 3 of the polio vaccine, 2 of the measles, mumps, and rubella doses, and then 3 of hepatitis B, and then 2 of varicella. And we have good vaccine coverage for our kindergarten students, as you see there. 2023 to 24, nearly 100% of them reported that they had completed the vaccines. So students can request exemptions from the vaccinations. And I think what I can glean from this is that there's a small percentage that have requested vaccine exemptions, but those are also going up slightly, but they're less than 1% or less than 2% for those who are requesting exemptions for religious reasons. And so, those are really just the information that we were able to gather, and we'd like to be able to use to continue to shape our programs kind of moving forward. And we're going to shift over to like what the health department has to offer to the school systems. And this is just really just an overview of what our organization looks like. But I do want to say there are corrections in there. So we have 4 divisions, and then also divisions that provide financial and administrative support that are not listed there. But the ones on the left, the community health division and behavioral health division, are the 2 that contribute the most to school health. And so the services are listed there. This is really for everybody, but we will more specifically talk about the programs that support school health. I just wanted to put a correction in there. So minority health is not, we've changed the name of that. It's really health education and outreach program. And then health promotions encompasses a wide range of activities and programs, and tobacco cessation really falls under health promotions. And then health promotions also includes chronic disease prevention, cancer prevention, screenings, etc. And then if you look at the second box for under behavioral health, so behavioral health services also include crisis hotline services. Okay, so for community health, community health does a lot of things. And hearing and vision screening are one of those supports that they provide to the schools, and these screenings are really critical, especially at the ages that you see there, because any visual impairment or hearing impairment can affect their learning, and we are glad to provide these services to the schools. So we conduct hearing and vision screenings, and if they're a positive screen, then the school health services nurse assists us by contacting the family and providing that information to the families so that their children can be referred to physicians and providers who can further evaluate those findings from the screening. And I would like to say that, in our interaction with the school health services nursing, sometimes they say that the parents do not respond. Or, there's a lot of challenges in getting them to do this. But I think they need to understand that that's actually could negatively impact their children. So we're working with them to find ways on how to improve that. And also, let's see. So immunizations. So our team at Community Health also provides lots of immunizations to help the children get updated in their vaccines. So when they enter school systems as kindergarten students, they're up to date. But then as they progress through their time in school, they're going to be due for several more vaccines, including one for tetanus, diphtheria, and pertussis, and then meningococcal vaccine. So we conduct back-to-school clinics, and those clinics provide vaccinations and then our nurses administer those vaccines at the school site, to improve access for the children. And then it's not only for the 6th graders. So as the school health nurses screen their records, if there are students who are lacking in vaccines, then we administer those as well, or my staff administers those vaccines to kind of help them get up to date. And every year we administer nearly 1,000 vaccine doses per school year to support the schools.
But again, the parents have to be engaged in this.
Yes, the parents. So we can't. They have to consent, right?
Mhm.
And if they request an exception, then their exemptions are honored.
Mhm.
Okay, and then for outbreaks, if we get reports of increased rates of certain diseases, our team conducts contact investigations and then come up with a plan for controlling whatever that condition might be, and then implementing those control measures. And then the lead poisoning prevention program is also one that we're running. There are not too many students in that, but if a student has an elevated blood level, then they are enrolled into that program even during their time in school. And if the levels, we're in consultation with the experts at Maryland Department of Health as well. And if there's a need to recommend treatment, then we make those arrangements to get them the care. And they stay on that program until lead is no longer a threat to their health. There's also a good amount of education that occurs for the parent as well as for landlords that might be involved in there. Okay, and then, so health education and outreach. This is actually the program. These are the programs in our community health division that we're hoping to make an impact, with the students, with all the data that I presented earlier. And so, yeah, they really play an important role in health education and outreach at the schools. And this is conducted through multiple mechanisms, and they're shown up there: open houses, a lot of health fairs. Our staff also gets involved with specific schools and provides in-services to their staff, their teachers, as well as their school safety officers. And if there are clubs, student groups who are interested in receiving technical assistance, our team very gladly provides that assistance to them. And on occasion, there are special programs that are organized by my staff. An example of this would be there's Dr. G, as a physician from Johns Hopkins University, who is scheduled on May 19th to give a talk about vaping, the adverse effects of vaping. And it's geared towards the community. So it's geared towards the student, their parents, and the community. So we can provide additional information about that if that's something that the council is interested in. And then, yeah, we just support them in multiple ways that are shown up here. And we have excellent staff who are dedicated in getting this done. I'm gonna turn it over to Ms. Dickerson.
Shifting gears, so I'm going to talk a little bit about the behavioral health services that are available through the school system. I think it's important to note, though, that behavioral health services are offered throughout the entire community, and that children aren't limited to just seeking services within the school system. And in fact, often children opt to seek services at the clinic just because they don't feel comfortable maybe seeing a therapist or a nurse practitioner within the schools. In fact, we actually probably have about equal amounts of children seeking services in our clinics as we do within the school system. We're working to make access equitable within both areas so that children have the option, as well as families, to seek both of those services wherever they wish and whatever is most convenient for them.
Okay, as the term children is used, but again, don't they have to have parental consent?
So that's an interesting question. So we talk about behavioral health as a global term, but there's actually a specific law that's specific to mental health and then substance use treatment. Federal law for substance use treatment actually does not have an age of consent. However, therapists, of course, would want to ensure that a child has the ability to give informed consent and understand what it is that they are actually agreeing to. And additionally, we would always encourage that children would want to have parental involvement at some level because a child is not an island, they're part of a community and part of a family. But federal law actually protects the treatment of anyone for substance use and the confidentiality of seeking that. For mental health, actually the state of Maryland allows for a 12-year-old to provide consent if they have the ability to be able to give informed consent. Again, that's up to discretion and whether or not someone believes that a 12-year-old has the ability to give informed consent for therapeutic services, not medication. That's, again, a discretionary issue. Again, we would strongly encourage that all children, youth, have their families involved because they're, again, going to go home to different environments, and we want to encourage them to have an environment where they can all support the work that's being done within those sessions. A very tricky situation there and requires a lot of navigation. So within the school systems in particular, it's a little bit more difficult because there's also consent that needs to be given for us to be able to see the child within the schools. So with our school-based services, we actually provide individual and group services, and we have just started piloting medication management within 3 schools within Calvert County. We have therapists in nearly every school in the public school in the district. I think the exception right now is 4 elementary schools. We have a behavioral specialist that's assigned to the Judy Center and also assist with Head Start. And then we have nurse practitioners, like I said, in 3 pilot schools. It's Calvert Country, Calvert Middle, and Patuxent High School are the ones that we're piloting at the moment. And Caitlin Liptak is our school-based therapist supervisor, actually. So looking at our very early young children, in the Judy Centers, there's 4 locations. We have a behavioral specialist that's dedicated to providing services here. And one of the nice pieces of this is that they work with not only the teachers, the students, and the families to provide some coaching and support to all of those individuals for developing appropriate social interactions, behaviors. things that would make them school-ready and able to be successful as they move through the public education system. That behavioral health specialist also supports the therapist that's dedicated to the 4 Head Start locations, who's able to provide individual therapeutic interventions to each of those kids and their families if those things are needed. So this is the number of students that we have seen over the past, I guess this is 6 months. You'll see that we have approximately 300 and I think it's 50-ish students currently enrolled as of April 1, I believe is when I pulled this data. So far we have served 550 students this school year. So to reconcile that number, those are individuals that may have come into services and then have subsequently left, either because they've chosen to leave or they've been successfully discharged from the services that they're seeking. So to give you a breakdown of the kids that we are seeing and what they look like, who's seeking services, I found this kind of interesting in terms of what age groups are seeking services because it's pretty equal among the genders, male and female, in terms of who's actually seeking services. And then in terms of, and even as you go through the age groups, I thought it was kind of interesting. You see a slight decrease, obviously, with as they get older, with males seeking services less. But this was something that I found kind of fascinating, that we see a discrepancy with the number of individuals in terms of females that have depression symptoms or report serious thoughts of suicide, but yet we see nearly equal numbers of males and females that are seeking services. Here's a breakdown in regards to race with regards with the students that we've been seeing. And then ethnic backgrounds. And then these are the primary presenting concerns that we're seeing from students across all of the age groups. The primary number one being adjustment concerns, and adjustment disorder is something that's a very large category. It's essentially when an individual has a difficult time or their coping skills are exceeded by a situational event. So it's oftentimes someone comes into therapeutic services because something has happened in their life, a transition from elementary to middle school, a divorce, a new family member. So these are situations where we may say that they have an issue with adjusting to that situation. Attention deficit disorder and hyperactivity, symptoms of anxiety or depression. Unfortunately, we have a lot of children who have experienced trauma. So we deal with a lot of those children who have subsequent symptoms. Individuals who have been diagnosed with autism, and then also developmental disabilities. We have a lot of children who we're seeing and providing services for those. And there's our contact information. Any questions with regards to the behavioral health services?
Ms. Nickerson. So going back to Dr. Teneza-Moore's presentation, there certainly seemed to be a higher rate of depression and suicide attempt rates with girls in the system. Are there any reach out efforts to those populations to make sure they're coming in for treatment at the school?
So I can tell you that there's not a current effort at this moment, but because of the trends and because of this data, we've actually recently written a proposal to target specifically depression and suicide rates because Calvert County actually has one of the highest suicide rates in the state of Maryland. So we actually have a targeted initiative that we're looking at to implement for next school year that is looking specifically at monitoring those things. In addition, and one of the things I didn't talk about at nauseam, because we've talked about it a lot, is the consortium and the blueprint money. So we've been the recipient of a grant, and we have applied again for another grant under the blueprint. One of the things that we are committed to doing is actually, and actually I think Pastor Jones, you sort of alluded to this a little bit, is ensuring that the things that we're doing are being effective. So we have invested in what we call measurement-based care, which is a platform that allows us to actually track the objective data. So our clients will be able to respond to validated screening tools. So for instance, if it was about depression or suicide, and track their symptomology over a period of time to ensure that the things that we're doing are effective and we have positive outcomes, or if the things that we're doing are not effective, so that we can make changes to that. So those are things that we're actually targeting for next school year and already making plans for.
Thank you.
Mr. Chairman, I have 2 questions. Perhaps 3. On your earlier slides, you talked about physical activity, and you said 48% of high school students report they are physically active. How does this survey define physically active?
The survey defines it, they have to have sort of like they have to have reached a certain heart rate. And, you know, it's moderate. It's gonna have to be at least a moderate or higher. But I can look into that a little bit more. But I know it's moderate based on heart rate.
All right, thank you for that. Second question, you partially answered, and it struck me that the suicide rate is quite concerning. And you said it is among the highest in the state. Do you have comparisons about how it rates nationwide?
I don't recall that data off the top of my head. I know that it was data that I gleaned from the recent roundtable and community needs that Calvert Health, the hospital, did. We actually used that data as part of our proposal for targeting the suicide and depression initiative.
Thank you. And I have one final question that you may or may not be able to answer. And do you have any recommendations about how this committee can use these data points to result in recommendations for improvement in these areas, some of these areas?
I think that's a very large question. and I think I'm a little biased because I sit on the council. As we were going through some of the data, I know for the subcommittee I'm on, I automatically am thinking of the family engagement piece. Sitting in my space from Calvert Behavioral Health, one of the things we struggle with, and it's sort of a double-edged sword, is when we have students that are engaged in school-based therapy, oftentimes it's difficult for us to engage parents in the therapeutic process because they don't have to bring the child to the clinic, they don't have to come in and speak to the child. If you think about going to a doctor's office, you would never just have your child go back, you would speak to the doctor. However, access is an important thing within our county. Transportation is important. We want to make sure that everyone has equitable access to all of the resources. But we need to have that parental involvement as well. So we're trying to straddle those things. I think one of our efforts, going back to the reference to the measurement-based care, is it has multiple ways for us to actually send information out to parents via text, via email, so that parents can actually have a way of providing feedback in a way that it doesn't require them to come in or actively be engaged in a session, but they can simply click on a link, they can answer an email, trying to meet people where they are and make it a little bit easier. But I think that that's one of the things that we struggle with in terms of straddling the accessibility, but the engagement piece as well. I don't know if you have other thoughts.
Oh, I think, yeah, I mean, Denise answered it quite well. Let's see, for behavioral health, I was thinking more of the other items or the other data points that were brought up in here, including, vape use, for example. I think maybe we can make recommendation, or that the council can make recommendations to enforce these in the schools a little bit more. Because those students are at risk, but they continue to do it, and things seem to be kind of accessible to them. So, yeah, you'll have to bear with me. That's sort of like, I think that other things. So the physical activity, we could potentially improve those. I mean, the Healthy 2020 or Healthy 2030, I was looking for some target goals there, but there really are none. It just says you just got to push it up, increase those percentages. And if there are ways to make PE a requirement, because that used to be a requirement when I was in school. That's a long time ago. But now there are ways to get out of that. But I think if the students it's made a requirement for the students early, then hopefully they have some kind of a muscle memory or mental muscle memory. When they leave high school, they'll continue to practice the same set of actions into their adulthood, and hopefully live healthier lives than their predecessors.
Well, I'd like to thank you both for a very informative presentation.
I've got a couple of things. Do you guys have access to the panorama data that the school system gives?
I am not sure if we do.
I'm thinking that just because multiple data points is always, beneficial to provide you with a nice overview of what you can be looking to target, but that might be something you can possibly take a look at, see if you get access to that information, because it really does provide not only overall, but where you can specifically target certain schools that might need more support according to that data. So it might be something, and they take it 3 through 12, so be able to figure, would it be elementary, middle, or high school, and then kind of go from there. I think that would be a really helpful piece. I mean, you do work with the school system, so I think that would be a way that you could maybe get some more information that specifically looks at very specific parts of mental health. And then for the questions that are, I guess, connected to mental health, more specifically suicide, is there a way, or are there questions to ask about, and I know there was one about the cyberbullying, and it was funny you said that because I had just written down other questions connected to cyberbullying. So I'm glad that you had put that in there, so I could see that as well. But anything that would allow you to more specifically look at why kids are wanting to commit suicide. Is it bullying? Is it, family issues? Is there a way to look at it, a breakdown as to why they're doing that?
So I don't believe that they asked with regards. I think it was simply, have you considered
Have you
it?
thought about
and
it?
then I think that there were some additional questions asking in regards to the seriousness of that. But
Right.
there was no questions with regards to rationale.
Okay. Thank you. That's very informative. Thank you so much. Anybody else have any further questions?
I'm looking to see if you said it, but how many mental health therapists do you have serving the public schools?
So for clarification, not all of our therapists, we don't have a dedicated therapist to every school. Some therapists may straddle a couple of schools. A lot of that is based on need, and the caseloads that are associated with each of those schools. For instance, we may have someone who straddles 2, maybe 3 elementary schools, because need may not be great in elementary schools. But we do have some who are full-time at certain schools. So Caitlin just indicated it's about 13 or 14 at this point that are within the school systems.
And you referenced some nurse practitioners, and what's their role as well?
So our nurse practitioners, the pilot program that we have just started is to bring medication management services into the school systems with the idea that a lot of times the medication management appointments are normally very, very short, normally about 15 minutes, and we wanted to see if we could help with increasing school engagement and decrease absenteeism, because oftentimes people are bringing children, they're taking them out of school, bringing them to a doctor's appointment for about 15 minutes, and sometimes those kids aren't returning back to school. They may miss a full day. It's difficult and it's disruptive. So the idea being that we would start with first children that were already enrolled in our services and allow them to have their 15-minute appointment at the school so that there's less disruption. And that would still engage, the family has to be fully engaged in that service. But it also increases the idea of the treatment team so that we can have more of a community approach to how we're treating these children. So we're including their families, the school, the nurse practitioner, and then the therapist if they're involved in therapeutic services. So it gives them more wraparound services.
Thank you.
I have a few other questions and maybe comments. In your community outreach effort, do you have any, or have you prepared any short videos that could be used at community groups and churches as a means of increasing awareness around vaping?
Actually, there had been a few. I can get Miss Tammy Halterman, who's our primary.
Okay, have Tammy
Yeah.
reach out to me, and
Yes.
maybe we can find some other means to circulate them. Either she or Jane can reach out to us, and we'll see what we can do there. The parent engagement in the therapeutic process is a concerning factor for me, and when there isn't a response, is pupil services engaged in trying to facilitate parental engagement?
So I think it depends on if we have consent to be able to do that. Certainly we can't start services if we don't have consent. We can't engage pupil personnel services to do that. However, a lot of times those referrals are coming from the school system, so they'll be the ones to engage the families to request the consent or to initiate that process. So we really strongly believe in the no wrong door. So referrals can come to us for those services either from the child, from families, from the school system, from anyone really who has contact with it. Oftentimes they may even walk in through our clinics, and we may offer the services through the school if they feel that they may not be successful coming in to
If the
services.
request is from the child, is there a mandatory process to inform the parent?
Again, it would depend on what kind of services that they're engaging in, the age of the child, whether or not the child has the ability to give consent. There's a number of
How do you determine that? Because I'm a grandparent, and I'm trying to figure out how you do.
Honestly, I think our therapists would love if we actually had a checkbox for that. I think that clearly, it's trying to determine if a child understands the risks and benefits of it. I think oftentimes we as individually licensed therapists tend to be a little bit more risk averse when it comes to something of that nature. And again, because children aren't raised in a vacuum, we want to encourage them to be engaged with their family members and have them engaged in that process. We're talking more of the exception rather than the role of things. So that no child is going to be successful if they're just being seen individually and nobody's engaged in that service.
Okay. And finally, there's another outreach issue as those numbers are a little disconcerting with regard to the young ladies who are reporting issues of depression, et cetera. in the outreach efforts, are there efforts to reach out to the Girl Scouts, the 4-H, the churches, the Parks and Rec teams that are girls' teams, et cetera, et cetera? How, I mean, part of this issue clearly needs to be addressed by the community that they're in, as you indicated. It's not a vacuum situation. It's not, you know, although my grandson would argue that if I said to him, school doesn't cause depression, he would argue with me. But in the in the midst of that, the process of looking at this is realizing that there are multiple inputs that impact wellness and behavior, and how are we engaging at multiple levels to make sure that we are responding to what we see.
So I think that's a phenomenal question, and honestly, I think I'm gonna go back to the Blueprint and Consortium grants, because they actually address that. They go through a tier system, 1, 2, and 3. Tier 1 looks at prevention, 2 is at early intervention, and 3 is at therapeutic services. And
Mhm.
it's the idea of treating it through wraparound and moving upstream, which is something I think we've talked about as a council. And looking, again, kind of at our proposal for next year, and targeting suicide and depression rates. We've been working closely actually with the community health promotions team to be able to work with middle and high school students to address early indicators of depression, and educate students about those signs and symptoms, as well as how to build resiliency and life skills, but then also being able to provide some services on the back end of things where students who may be experiencing those symptoms of depression and suicidal thoughts, that we can treat them therapeutically. So that's definitely our initiative for next year that we're looking at trying to implement, is trying to target those things from both ends so that we can kind of work on preventing it, so that we don't have to be so reactive to things.
Okay. I have 2 more issues. One, of course, is one that you didn't report on, but it is a concern countywide, and it's that we've been running a trend of higher cancer than most places our size. And when we look at the impact of the areas in the state that have higher per capita cancer rates, we're among those. And the question would be, from a public health perspective, what policy initiatives and how early on, in terms of wellness, are we trying to address behaviors that will limit the incidences?
Okay, I'll have to get smart on what those specifically are,
Okay.
because depending on what the condition is, that determines what the early intervention
Sure.
might be. And I know that tobacco use is the #1 preventable cause of cancer. I think that if we continue to push the effort, with tobacco education, promoting prevention, and then promoting cessation, that's good. And that's a good start. The other thing is, we do have a small effort in community health in which they are advocating for cancer screenings. I think those can be built up with funding, of course. So we'll have to find creative ways to sustain those efforts in the midst of what we might experience in the next few months in terms of funding. And I can get back with you on that,
Sure.
Pastor Jones.
Sure. And finally, not as a part of Blueprint or any other special initiative that is grant-driven by, but rather by your core funding, what are the priority areas for wellness as they pertain to children?
That's a very good question. I think it starts with healthy eating and healthy health, diet, the very basics. What are the ones that will cost us the least amount? And start with those basics. Exercise, eating. I have a plan to I have a plan to get with the school system and the school health services,
Mm-hmm.
just to kind of take a look and just evaluate what the nutritional value. Because I've seen complaints, and sometimes maybe they're anecdotal, from a parent or from a colleague. Just take a look at the school lunches, the diet, and what the curriculum is in terms of nutrition and health as well, and see if there's some ways we can help improve that and streamline it or add our expertise to it. So I would say that would be a good start. And then mental health, because it's playing such a, mental health wellness. I don't have a good answer for that, but I'll have to get with my team and how to.
Sure, and
to look at the
we
prevention.
should have started off by welcoming you to our community. We realized that you're new, and we realized that we're dealing with old issues. And so I don't expect you to have a magic wand or to be here with one, but I just wanted to know, because one of the things I think that becomes important to us is, as we move forward to make recommendations, are there systemic things that can be a part of who and how we operate as a collective in this community that target wellness? I like initiatives, I like pilot programs, I like them for research purposes, but what I'm really interested in is a systemic process that exists as a part of the norm that basically lends itself to student wellness, not as a problem-solving crisis intervention piece, but rather as the core of what we do that keeps us well, healthy, balanced, safe, all those things. So that's what we're looking more for. And if, given our existing resources, are there ways that we can collaborate with agencies and do a better job with the existing resources to really promote student wellness? So those are the kinds of, I'm not, mining too many other things. I'm just trying to figure out what makes sense in this larger system to create the kind of environment we want for our young folks.
Mr. Chairman, may I speak just briefly to your last two questions and your last comment?
Sure.
And it regards this holistic, systemic approach. The general question I would have is anyone familiar with the blue zones? You were talking about the blue zones. For those of you who are not, Buettner was commissioned by National Geographic to put a team together to go around the world to identify the communities that have the longest life expectancy. And the 6 communities that he identified around the world he called blue zones. And typically these communities have life expectancies well into their 90s and beyond. So I think you have a general understanding, but what might not be evident is there are communities across this country that have tried to implement blue zones, and I actually worked in a community right outside of Richmond. It has the opportunity to save hundreds of millions of dollars in healthcare costs and other types of costs. And I think that's the type of broad, forward-thinking, proactive perspective that we can take. And there are certainly some examples of things that communities can specifically do that add value and not pull away from resources, but actually enhance resources.
Anybody else have anything to add? Well, again, thank you so much for your information. We are glad that you're here in Calvert County. We look forward to hearing all the great things that you'll do to help support us in the school system and in the community. So thank you again. We know it's a very big task.
Yeah, thank you very much. I really appreciate the welcome, and yes, so I'll work with my team. I have a team of great staff, so
you.
Thank you.
Okay, it is come to the point in our meeting when we can accept public comment. I believe Emily will take a look and walk us through if we have anybody online, and then anybody here present that would be willing to speak.
If you're online and wish to leave public comment, please press *9 or use the raise your hand function. If you're speaking as an individual, you have 2 minutes to leave public comment, and if you're speaking as a designated member of an organization, you have 5 minutes. Again, please use the raise your hand function now or hit *9. One more opportunity for those joining us online. If you wish to leave public comment, please press *9 or use the raise your hand function. Madam Vice Chair, we do not have anybody online wishing to leave public comment. Is there anybody in the room that wishes to leave public comment today? If so, please come to the mic now.
Okay, we appreciate everybody's attendance today, and we hope that everybody has a great rest of their day. Can I get a motion to adjourn?
So moved.
A second?
Second.
All in favor say aye. Anyone opposed? Any need for discussion?
They just want to stay.
The ayes have it. Motion to adjourn.